Thank you for coming here to today's Health and Wellbeing Board on Thursday the 14th of October. I will start with any apologies for absence.
Apologies from Paula Mead and Rick O'Farrell.
Thank you very much. I'll move on to minutes of the previous meeting. Can they be agreed as a true record? Agreed. Seconded. Thank you very much. I'll then go on to item 3, disclosures of members' interests. Do any members have any interests to declare? I cannot see any. So what I will do is, just to note, I'm going to move the agenda about. So I'm going to go to item 4 on the agenda next. Then after that, I'm going to go to item 7 and then get back into order. And we'll go into item 4, update on the epidemiology of COVID-19 and on the Northumberland COVID-19 Outbreak Prevention and Control Plan. I believe there are 2 presentations. And I believe, Liz, are you starting? Over to you, Liz.
Thank you very much. Hopefully everybody will be able to hear me over the whatever they're doing outside. Okay, so I'm going to try and run through this. Won't be running through it at all. Oh no, there we go. Try and run through this relatively quickly. So this first slide is just a sort of a summary of a national overview, and this is all information from the Office for National Statistics. So what this is telling us is that overall infections, so the prevalence of infection, so that's the number of people that we estimate at any one time have infection, is increasing. So it's gone up from 1 in 80 to 1 in 70, but it is more prevalent in the northeast. But despite that, hospital admissions are remaining roughly the same. Deaths nationally are coming down, and certainly that's being reflected in Northumberland. So we're seeing that deaths have reduced since the middle of September down to about 1 a day. The vaccination program, I'll go on to talk about that in a little bit more detail, but hugely successful. So more than 4 in 5 adults are now fully vaccinated. 9 in 10 adults have got antibodies, so that's either from vaccination or from previous infection. But of course, that doesn't mean that you're immune from further infection or that you can't pass it on. And the bottom right graphic is just looking at social distancing. So that's a sort of marker of the extent to which people are retaining those COVID-safe behaviours. And that's important because the longer we maintain those COVID-safe behaviours, the less likely we are to see an overwhelming increase in cases. And what it's suggesting is that actually, although social distancing as a measure of that has reduced, it's actually sort of levelled off. So it looks as though we're retaining a level of COVID-safe behaviour, which is really good news. And then this is again from the ONS Infection Survey, and this just shows the difference in the proportion of people testing positive by age. And what this demonstrates, if you look at that middle top graphic for school year 7 to 11, which is 11 to 16-year-olds, it just shows how much higher the prevalence is in that age group. So about 1 in 14 11 to 16-year-olds are estimated to be infected at any one time. That's in the week up to the 2nd of October. Whereas if you look at an age group which could be their parents, so those aged 35 to age 49, it's 1 in 83. And certainly in Northumberland, 40% of our cases are in people under the age of 19. And it is those 5 to 14-year-olds who are driving transmission at the moment. So this is the most recent dashboard, putting that into perspective from a national perspective. We're probably in about the top third of local authorities in terms of case rates at 464. Trafford's at the top. Their current case rates are 845 per 100,000. Some areas of Wales have got similarly high case rates. And our case rates are about the same as Lincolnshire, Hampshire and Worcestershire, but we have got the second highest case rates across the LA7. Some of the lowest case rates are in London, Bristol, Somerset. They're sort of rumbling on at about 150 per 100,000. So there is still a lot of variation in terms of transmission and rates across the country. In terms of the actual sort of outbreak control plan, we're still very much focusing on those high-risk settings and populations. Less of a focus on workplaces at the moment, partly because actually we're just not getting the complaints through about workplaces that we had before, and also, you know, a lot of the constraints that were in place have now been lifted. So there's less of an emphasis on workplaces now, but still very much a lot of support for educational settings, the care sector, and high-risk settings. From an educational point of view, we're still following the National Education Contain framework. The outbreaks that we're seeing in schools are largely contained to classes or years, so we're not seeing widespread transmission across schools, which some other places are seeing. Schools have got a range of control measures in place, so that includes hygiene, some restrictions of movement, ventilation, encouraging the use of face coverings in communal settings, and that seems to be largely managing outbreaks in those settings. There's lots of lots of testing being done in school-age children, so that's on top of the twice-weekly LFT testing. Lots of testing outside schools, and of course we are approaching half-term, which should provide us with a natural break. From a care sector point of view, we're seeing between sort of 10 and 14 incidents a week, which could range from, you know, 1 or 2 cases, and it is largely small cases in those settings, but we have seen a couple of larger outbreaks despite the high vaccination rates amongst staff and residents. We're seeing odd cases in homeless hospitals, residential care settings, and again the numbers in each of those are relatively small. As I've said before, we've had an ongoing outbreak in the prison for some time now. We have regular multi-agency outbreak control teams, and we have put in additional support around testing and vaccination within the prison. And just for interest, really, the Lindisfarne Festival, which took place at the beginning of September, was associated with quite a large number of cases, although a relatively small number in Northumberland. We're extending our local contact tracing offer. So cases are transferred to us earlier. We'll be doing that, I think, next month. And there is a national review of local testing centres and mobile testing units, so we may see some change. But at the moment, we're just continuing with the local arrangements that we've got to support lateral flow testing. And from an NHS perspective, you know, I think the whole of the NHS continues to be really busy. That's not necessarily to do with COVID, but that is you know, it's very pressurised and very busy. So just a little bit on the autumn and winter plan then, and just in case you didn't know, Public Health England ceased to be as an organisation at the end of September. So the staff or the function has been split between the UK Health Security Agency, so that the health protection functions have been transferred into UXA, which is what it's called, and the other functions have been split between NHS England and the new Office for Health Improvement and Disparities. So the winter plan is really orientated around promoting the flu and COVID vaccination program, continuing down the routes for testing, contact tracing and supporting people to self-isolate, encouraging individuals to maintain all of those COVID-safe behaviours that we've been promoting for the last 18 months, and then the retention of some of the COVID regulations. And the Plan B which will be implemented based on pressure on the NHS, has some additional measures around the reintroduction of face coverings, the use of vaccine passports, encouraging people to work from home and promoting the need for caution, and hopefully that will be sufficient to contain transmission should it escalate beyond where we are at the moment. Just a quick update on the vaccination programme then. Just to say, actually, that GPs and primary care staff have done an absolutely phenomenal job. They've given nearly 500,000 doses of COVID vaccine in Northumberland. We still have the highest uptake of first and second doses. It's pretty early days with the 12 to 15 programme, and what you're seeing here, which is basically a comparison of uptake between Northumberland, the North East and England, and it's showing actually how much better our uptake is largely compared to both England and the North East, except when it comes to the 12 to 15 programme, and there are reasons for that. That picture is very similar for second doses, except the 12 to 15 programme. So, a phenomenal job being done there by primary care colleagues. Just talking about vaccinations in young children or children and young people, because it's a relatively complicated picture. So 16 and 17-year-olds are receiving one dose, and they've got a variety of mechanisms to access vaccination. So they should all have received a national invitation. They can go into walk-in clinics, pop-in clinics. They can be vaccinated through primary care networks, pharmacies and vaccination centres. So lots of opportunities for 16 and 17-year-olds to be vaccinated, and actually the take-up is really high. For vulnerable 12 to 15-year-olds, so that's 12 to 15-year-olds who've got another health condition, they will receive both doses and they'll be vaccinated through their GPs. And then we've got the healthy 12 to 15-year-olds who are going to be vaccinated through the school immunisation teams. And just to sort of pick out a few points here about the 12 to 15 programme. So generally the school's immunisation team it's a separate team. It's commissioned by NHS England. They are working on a no consent form, no vaccination policy. It doesn't mean that those children can't be vaccinated at a later date, though. But I think what the board needs to just bear in mind is the size of the task, and actually none of us should underestimate the size of what this very small team is being asked to deliver. So, we are expecting a small team to act at scale and pace, and that's on top of an expanded flu programme. So it's extremely challenging, but what we are good at is working as a system across the region and locally, and we are pulling out all the stops to support the workforce and to support the delivery of this programme within the required time frame. I think the uptake is higher than perhaps we thought it was going to be, but lower than flu. But you can see that there's quite a range of uptake, quite a difference in uptake between schools. So it ranges from 16.5% to 77%, and there's a number of reasons for that. But the programme is, it's got a range of challenges. Firstly, the turnaround time to get consent back from school children and their parents, issues around workforce capacity, these, inequalities in terms of uptake across communities, and some uncertainty about the secondary offer, because obviously we need to put in place some sort of process to mop up all of those children who were unable to be vaccinated the first time round, and that's a bit of work that we're doing at the moment. So as we move into the winter then, where obviously into the booster programme at the moment. That's recently started. And those can be given not sooner than 6 months after your second dose or after you've had the primary course of the vaccine. So that automatically means that actually the rollout of the booster programme will roughly follow the rollout of the original programme. It does make sense for both of those to be given at the same time, but they don't have to be given at the same time, and there's a very clear direction that one programme shouldn't delay the delivery of the other one. But I think the real priority is to get those most vulnerable people in care homes vaccinated, because the evidence is that immunity wanes over a period of time, so we really need to ensure that that most vulnerable group are vaccinated as a priority, and there's a target for completion by the end of November, but end of October rather. So it's very early days, but actually the feedback that I've had from the regional team is that certainly flu uptake looks as though it will be higher than it has been in previous years. So next steps then, really this is about encouraging vaccination. First doses, second doses, boosters, and particularly high-risk groups like pregnant women. Pregnant women have died of COVID. We have pregnant women, not necessarily in Northumberland, but there are pregnant women in ICU, across the country. This is a really important group to get vaccinated. As I said, we're looking at the development of a secondary offer for 12 to 15-year-olds to support that school immunisation programme. And we just need to keep communicating proactively and effectively with our patients and the public, particularly around the vaccination programme. So just in summary, we have seen COVID cases gradually increasing. They've been fluctuating quite a bit, but the general trend is upwards, and that fluctuation actually is seen in other local authorities in the North East. So it's not just us. Not quite clear what's behind that. Still largely driven by 15 to 14-year-olds, but certainly nationally it's levelling off. And actually, when we look at our own data, the cases look as though they are starting to level off as well, which is really good news. We've got the winter flu plan, but there's not much in there to prevent super spreader events. So that's things like festivals, concerts. We're repeatedly seeing spikes of cases associated with events like that. Again, we really need to focus on vaccination coverage and continue to focus on areas of inequality. Continue to focus on the 12 to 15 programme and the booster programme. And as I said, we are looking at how we can develop a secondary offer for those children. And just to say that, we've seen 1,500 cases in the last week. We've still got a case rate which is, nearer 500 than 1,400. So for me, it doesn't actually feel as though this pandemic is anywhere near over. So still need to be, cautious, kind, considerate. Very happy to take any questions if anybody has any.
Yeah. I'll go to Jeff Watson and I'll go to Pat.
Thank you, Chair. One comment and then one question. This COVID-19 death thing that you sent out to me, I really appreciate this. This is the request that if you recall, I spoke about.
Going to do that presentation.
Going to do that in a minute. Okay,
yeah.
Fine. I'll leave that then. Okay. Okay. Get to my question then. The combination of the flu vaccine and the booster vaccine. Is it? I'm of a certain age, so I'm involved in both of those at the moment. So we were invited for our flu vaccine, which we had to ring up for. And I think you can imagine it's actually quite a busy phone line, so it takes quite a long time to get through. But we've got that. And I've got it for this Friday afternoon for my wife and I. We're both due to get booster injections for COVID. Why can't they be married up? because at the moment I'm going into the surgery to have my flu one, and I don't know when I'm going to get the other one, but I know it's just about due. Isn't technology clever enough to sort of put the two together?
So I'm going to ask Graham to answer
I know,
this.
thought you would.
The COVID vaccines coming into the system are not necessarily coming in line with the flu vaccine. So you'll see on Liz's presentation, it says, don't delay giving one for the sake of not having the other. So if there's flu vaccines available for somebody in your risk cohort, you will be offered and you will be given. If it happens that we have flu vaccines available for a cohort who are also getting their COVID vaccine, there'll be an opportunity to have them both on the same day. But it's a really difficult logistical exercise at the minute, marrying up the people who are due they've done 6 months and they're due their third jab, and their flu vaccine is available. And it will vary from practice to practice across Northumberland about how they're doing it. So it's just as soon as we can get them out, we're doing them, essentially.
I just, you know, I appreciate that, but obviously it'd be better for patients and quicker and better for the surgeries as well to do the two together, I would have thought.
Absolutely, and wherever possible.
That's what you're doing. Yeah. Okay, thank you.
Thank you, Chair. First of all, I think it's probably been said before, but I think the rollout of the vaccination programmes, I've heard nothing but praise about how wonderful everyone was treated, so quick, so efficient. I just think we really need to congratulate everyone concerned. I certainly thought it was terrific, very, very efficient. If I could just move on to the prison, Liz, I just wondered what precautions do they take around visitors? Is there any visitors allowed yet? You know, were visitors stopped during COVID? What's that scenario? Just with the prison being, as you said, a lot of cases?
I'm pretty sure that they are allowed visitors, but I'll check what constraints were put in over the, you know, when the case rates were much higher. I think, you know, the prison is a challenging environment. The uptake, you know, we'd like to see uptake of the vaccination being, you know, higher than it is. We don't have particularly good data on vaccination uptake in the staff that work at the prison. And of course, there's always that balance about, you know, security and maintaining the safety of the staff and the residents, which does sometimes make the delivery of care quite challenging. But I'll ask about visiting.
Thank you. And just very briefly, the walk-in clinics for young people for the vaccination, how many do we have? Are there a lot in Northumberland? You know, or do people have to go to Newcastle? Where are our walk-in clinics?
So I think community pharmacies offer a walk-in option for 16 to 17-year-olds. I think primary care networks offering vaccinations.
I don't think the primary care networks necessarily offer a walk-in. I'm looking at Rachel to see if, you know.
No, the primary care's not doing the walk-in, but community pharmacy are. So that's where the young people are being sent to for their vaccines.
I just wondered what the uptake was in doing that. My grandson went to somewhere in Newcastle called Grab a Jab, and I thought that was quite amusing and quite, if you like, would attract young people more. Not that anybody wants to go for a vaccination, but I just thought it was quite quirky. Grab a jab. I just thought that was a good thing. Thank you very much.
Wendy, sorry, just to come in there, we are offering the grab a jab. So the practices, as and when they've got vaccines, they are putting clinics on. So we are using that grab a jab because you're right, it is quite good for attracting younger people.
It is, yes.
Yeah,
absolutely.
so we are using that, and the practices can opt into that if they. So they might be offering a clinic and then they'll just put that on just to advertise for people to come. So yes, sorry, I had forgotten about grab a jab. So yeah, that is available.
Excellent. Thank you. Thanks very much.
Thank you, Chair. It's Jane Lothian. I'm the LMC representative for the GPs. And just to reinforce what Graham and Rachel were saying is that behind this sort of apparent illogical, non-marrying up, is that unfortunately our leaders in the centre have frustratingly not married up all the contractual arrangements between pharmacies, flu, COVID, etc. So, the practices are attempting to deliver vaccines together, but literally the number of variables is so great that it is sometimes not possible. And the things that the practices are allowed to do compared to what the pharmacies are allowed to do and the other centres vary contractually. So it's unfortunately this year it's very, very difficult to deliver everything in a completely streamlined fashion. So I just wanted to, it's not for want of trying. So, and it lies in the contractual arrangements.
Absolutely. I'm sure we're all working on rules we're given, aren't we, sometimes? Yes, gentleman there.
Thank you. David Thompson, Health Watch Northumberland. Just like to echo the comment made about the wonderful efforts made by GPs and the whole system, public health, in terms of vaccinations and boosters. It's quite a remarkable achievement, and I'm sure the whole community will be very grateful for that. But within all of that, it's particularly reassuring that Liz and her team make strenuous efforts to contact the hard-to-reach groups, because that was very, very important. But I think now I would class the 12 to 15-year-olds as a hard-to-reach group. And I speak from 2 grandchildren of our own, and they do have very, very conflicting messages from within their own family, but from within the web. And I know how confused they are about which way to go. So as you've said, just would encourage you to redouble your efforts after half term to try to catch up those who are still uncertain, and perhaps to reinforce the very, very positive messages about youngsters receiving the vaccine, because I do know that they are still confused about what is right and what is wrong, what is safe and what is not safe, particularly the long-term implications of all of this. Okay, thank you.
Okay, are there any more questions or points there? Can't see any, so we'll move on to our next presentation, and I guess it's this one here.
Hello everyone, so my name's Catherine Bush and I'm a Speciality Registrar in Public Health, and I'm based here at Northumberland County Council. And throughout the pandemic. Sorry about that. And I think just before we start, the one thing that I'd just like to acknowledge is that sometimes when we talk about deaths from a population perspective, it can sound somewhat dispassionate, and in public health we do recognise that each of these deaths represents but from a public health perspective, what we really need to do is look at things both on an individual level and also.
Just 1 second, I think your mics, you've got a dodgy mic, so I think we might want to try and replace your mic.
Can you hear me now? Is that better? A little bit. So I'll try and speak up as well. So basically what I was saying is that we recognise that each death that we talk about today represents an individual, their families and their stories, but from a public health perspective, we also need to look at things from a whole population level, and that's what the focus is going to be on today. Oh, sorry. So the contents of today's presentation is I'm going to give you an overview of deaths in Northumberland throughout the pandemic. We're going to look at some variations in death rates according to the age of the population and the wards that people live in. And we're going to talk about 2 terms that you may hear about in the media or you may already be well aware of, which are excess deaths and breakthrough deaths. And then we're also just going to touch on the role of vaccination in preventing deaths. So if we look at Northumberland from a whole pandemic perspective, and these slides were prepared about 2 weeks ago now, so they're slightly out of date, but the total number of cases at the point this presentation was prepared was just over 35,000 cases of COVID-19. And throughout the pandemic, we'd seen just over 3,000, so 3,315 hospital admissions. And then there are two different totals of deaths which are often given, and I think it's important that we just touch on the difference between those, because sometimes one is presented and sometimes the other. So the two figures that get presented by the Office of National Statistics and the media, the first one is the total number of deaths within 28 days of a positive COVID-19 test. And we've seen 743 of those deaths in Northumberland throughout the pandemic. And that figure is used because there is a risk that sometimes not all cases which are linked to COVID-19 are actually acknowledged on the death certificate or acknowledged at the point of death. But it may also include some deaths which are not related to COVID-19. The second figure, which is presented, is the total number of deaths with COVID-19 on the death certificate, regardless of the point that it occurred. So these are the total number of deaths where a doctor, when certifying the death, thinks that COVID-19 was the main cause of death or contributed to the death. And throughout the whole pandemic, we've seen 817 deaths in Northumberland, which have been classified in this way. So what I'm going to do now is take you through this slide, which comes from the Office of National Statistics from the government. And this looks at the daily number of deaths that we've seen throughout the pandemic in Northumberland within 28 days of a positive COVID-19 test. So each of the little blue lines that goes up represents a day, and it represents the number of deaths that were seen on that day. And if you look at the axis on the left-hand side, you can see that the number of deaths in Northumberland on a daily basis has ranged between 0 and 10 throughout the pandemic. And on the bottom, you can see that there is a timeline. So in the far left-hand corner, that's the very beginning of the pandemic. So that's around March 2020. And if we follow it along to the right-hand side of the slide, we can see where we are now, or where we were at the point I prepared the slides, which was the end of September 2021. And what you can see clearly from these slides is that we have seen peaks of deaths. So we saw peaks of deaths in Northumberland at the beginning of the pandemic, and then we saw another one towards the end of 2020, the beginning of 2021. But what you can also see is that actually we've had quite long periods in Northumberland as well, where we haven't seen any deaths at all. So we can see that in 2020, in the summer, there were very few deaths reported. And we then had another period throughout 2021, from kind of April into July, where we didn't see any deaths before the numbers have started to rise again slightly. So what this slide does is look at where we've seen these death rates, the deaths occurring. And this is presented as death rates. So this is not numbers of deaths, this is rates of death. And these are rates per 1,000 people in the population. So if you focus on the blue bars at the moment, we can see that in the lower age groups, the numbers are actually very, very low or zero. It doesn't show on the slides, but the kind of the death rates in the lower groups are so small that they don't show up. So, for example, in the 20 to 39-year-old population, the actual numbers have been around 3 per 100,000 people in our population. But as you can see, as people get older, the death rates have increased, and this kind of reflects what we've seen nationally as well. So in the 90-plus age group, we can see that there have been around 55 deaths per 1,000 people who've had COVID in that age group. The orange line represents the case rate, and this is just to show you that the number of deaths is not proportionate to the rate of COVID. So as Liz touched on before, the highest rates and the highest rates overall have actually been seen in the younger population, and that's important. So what we're moving on to think about now are the number of deaths which have occurred in wards throughout Northumberland. And we thought it was important to include numbers as opposed to rates to put this into perspective so that you have an actual idea of the number of deaths that we've been seeing in wards throughout Northumberland. So the top line are the wards where we've seen between 0 and 10 deaths, and the bottom are the wards where we've seen the highest number of deaths, so between 31 and 40 deaths. And those wards are listed in alphabetical order, they're not listed according to numbers. Because the wards are, of course, of different sizes, it's also important to think about death rates. So again, what we're looking at here are rates of deaths per 1,000 people in the population. So if the reason for that is, for example, if you compared a very large ward to a very small ward, if you had 1 death in each, what that actually means is something quite different. So what we can see down on the left-hand side are the wards which had the highest rates of deaths throughout the whole pandemic, and those on the right-hand side are the wards that had the lowest rates of deaths throughout the pandemic. And of course, the next question, when you look at that and you see that there's quite significant differences, is to think about why. So I think the first question to think about is it due to rates of infection within the wards? And the answer to that is that it appears no, it's not. So the little orange dots again represent the rates of COVID-19 infection in each of the individual wards, and you can see that there is no pattern in terms of the rates of infection compared to the rates of death. And what we're not going to do is talk about individual wards in detail, but what we think as a public health team is that these differences represent differences in the populations that each of the different wards contain. So we know that some of our wards contain much higher numbers of people who are elderly, so in the 80 to 90 plus population, and we know that those wards have seen higher death rates. We also know that in some of our most deprived populations and populations where people are suffering from ill health or multiple underlying health problems, we know that in those populations we've seen higher death rates as well. So I don't think there's one simple explanation for the variation, other than to say that we do think it reflects the age and the health of the underlying populations within the individual wards. So we're now just going to move on to talking about excess deaths. And this is a term that you may hear in the media. And this is just an explanation of what excess deaths are. So excess deaths are the number of deaths from all causes above which we would have expected to have seen during a given time period compared to the previous 5 years. So if we take a week during the pandemic and we count how many deaths there are, we then compare that to the same week in the previous 5 years and see whether or not there have been more deaths or less deaths than we would expect. And if there are more deaths than we'd expect, this is referred to as excess deaths. And the reason that we look at excess deaths as well as just COVID deaths is that this captures all of the extra deaths which have occurred during the pandemic, probably because of the pandemic, but are not specifically related to COVID, having COVID itself. So this would, for example, include people who, during the peak of the pandemic, were unable to access healthcare for other health conditions and unfortunately died as a result of that. Excess deaths also, however, recognises the fact that actually at some points during the pandemic we might have seen less deaths than we expected. And the reason for that is things like all of the social distancing measures that were put in place actually meant that last year we had less flu. So actually, there would have been less flu deaths than we'd expected. So the overall number of deaths might actually be lower. So this is a timeline which looks at excess deaths during the pandemic in Northumberland. So again, along the bottom, we've got a timeline which starts on the left-hand side and moves through to the right-hand side to the end of the pandemic. It's slightly different. This is the way that it's represented on the Office of National Statistics website, in that it looks at weeks of the pandemic as opposed to actual dates, but it's the same time frame. And what you can see on this graph is that whenever we've got a blue line, we've had more deaths in Northumberland in that week than we would have expected to see compared to previous years. But whenever we've got a yellow line, we've actually had less deaths than we'd expect to see in Northumberland compared to previous years. And you can see that throughout the pandemic, we've had periods where we've had higher numbers of excess deaths, and then we've also had periods where we had less deaths than we'd expect. And this slide just attempts to show you why that might be. So on the bottom, we've got another graph which looks at all the deaths by week that have occurred in Northumberland. So that's the grey bar at the bottom. And then on the top of each grey bar, there's the red line which represents the deaths from COVID-19. And you can see that the number of excess deaths has gone up, and that represents the COVID-19 deaths. So throughout the whole pandemic, up until week 37, which was the end of September, we'd seen 849 deaths with COVID-19 on the death certificate. And when we look at the expected number of deaths during that time period, we would have expected to see during the entire pandemic period in Northumberland 6,273 deaths. The actual number of deaths that we've seen was 6,638, which means that the total number of excess deaths in Northumberland that we've seen throughout the pandemic is 365. So that's 365 deaths more than we'd have expected to see for the time period. And actually that number is a lot lower than I think we expected at the very beginning of the pandemic. And there are a lot of reasons for that, which you're all aware of. So all of the social distancing measures that have been taken, the use of PPE, the test and trace programme, and probably the biggest game changer, which was vaccination. And as Liz touched on in the previous presentation, at the point that this presentation was done, the number of people, or the proportion of people that were eligible for vaccine sat just below 90% for the first dose and 85% for the second dose. So now I'm just going to introduce you to this other term which you may be hearing about, which is something called breakthrough cases and breakthrough deaths. So breakthrough cases of COVID-19 are cases of infection which have occurred in someone who is fully vaccinated against COVID-19. And breakthrough deaths are defined in the statistics as a death involving COVID-19 that has occurred in someone who's received both vaccine doses and had their first positive test for COVID at least 14 days after the second vaccination dose. So they're people who, if the vaccine has been effective, should be protected against COVID-19. So why are we seeing the number of breakthrough COVID-19 cases and related deaths rising? Well, this is to do with statistics, and it's not to do with the fact that the vaccine isn't working. So all of the vaccines that are currently in use have are effective in approximately 90% of people. So they're 90% effective around that figure, which means that if you vaccinate 100 people and then expose them all to COVID-19, around 10 of them may still get COVID-19 and the potential of dying from it. And they would be judged as being, or labelled as being a breakthrough death. Now, the more people that you vaccinate, the more breakthrough cases and breakthrough deaths that we get. And that's because the more people that have the vaccination, the more people there are that will fall into that small group that are not protected. And those are the people that can get COVID-19 and unfortunately could die from it. So it's just to let you know that we do expect to see the number of breakthrough cases and breakthrough deaths increasing alongside an increased prevalence of COVID-19. And that's not an indication that the vaccine is not working. So if we just take you back to this slide, and we're just going to talk a little bit more about vaccination. This takes you back to the Northumberland deaths throughout the entire pandemic period. If we look at what the cases in Northumberland are doing, you can see that the cases have started to rise, but the deaths are not rising in line with those cases. And we can also see that the hospital admissions are also not rising at the same rate as the cases as they did previously. Now, we don't have data for Northumberland at the moment which specifically looks at the deaths in people that have been vaccinated, but we do have the information for the whole of England and the deaths that occurred between January and July 2021. And this table, which is the last table I'm going to show you today, is a really important one. So this table looks at the vaccination status of people who have died during that time period, and it looks at deaths which include COVID-19 or deaths which do not involve COVID-19. And we can see that during this time period, if we look at the first line, all deaths regardless of vaccination status, there were 51,281 deaths which involve COVID-19. But most of those deaths, so 38,000 of them, occurred in people who were unvaccinated. So by far and away, the biggest majority occurred in the unvaccinated population. And if you look in the second column right down at the bottom, you can see that of those 51,000 deaths, 458 of them occurred in people who'd been vaccinated. So the rates of death in people who have been vaccinated are very, very low. So in summary, we've seen around 849 deaths with COVID-19 on the death certificate in Northumberland, but there have been a total of 365 excess deaths for this time of year throughout the entire pandemic period. The highest death rates from COVID-19 have been seen in our oldest residents, and the numbers of deaths has varied between wards throughout the pandemic. Deaths in Northumberland have been limited by the measures taken, including the social distancing, lockdowns, the use of PPE, infection control measures, test and tracing and vaccination. And important to remember that the number of breakthrough cases and deaths will rise with increasing vaccination. This is expected and not an indication of a problem with the vaccine. And very, very few deaths are occurring in people who've had both vaccine doses. That's the end.
Okay, thank you very much for that. I've got a question from Jeff Watson to start with, and we'll go from there.
Let me finish up first. Thank you for that. I started to say it before, but after actually hearing you take us through the presentation, it sort of adds strength to what I was going to say. It's rarely that when you ask a question, you get such a comprehensive answer and so well put forward, so that you can completely understand what it is you were saying. I think this document is really, really interesting. It certainly answered a lot of questions that I've been asking, and my constituents have been asking as well. So I want to say thank you very much indeed for it. I just have one very small point. You were talking about average 5-year deaths. Obviously, the statistics and damn lies, I think it is, isn't it? But are we able to take into account sort of changes in population in Northumberland? I mean, I'm wondering, we've seen that we've got 365 excess deaths. Do we know if we've had an increase in our population which would increase the number of deaths we would expect, or is that just getting too complicated to for the purpose of this report?
It's a good question. I mean, the one thing that we do know about Northumberland is that actually it has a relatively stable population compared to other areas. So actually we can most of the time really quite comfortably compare year on year. I don't know if Liz has got anything else that she'd want to add to that.
No, not really. No, I think it is a reasonable comparison because obviously the population does change, but it's not changing that rapidly that we can't use that as a comparison.
I think Jeff's got the same issue I have, that we're two little pockets where the population is rising quite both of our wards, but that's possibly not representative of all 67 wards, to be perfectly honest. So that's very interesting. Thank you. Any more questions or issues?
Yeah.
I'd like to see yourself on the list. Yes, David.
Thank you. Just again, thank you for the presentation, which was very, very illuminating. But what would be the key lessons to learn from all of that in terms of communication, engagement, in terms of policy and practice? Looking ahead to perhaps the winter and even beyond, what key messages, what can we learn, what can we do as a result of all of that? Thank you.
So I think the key message is that the measures that have been taken by the public health team, by the NHS and by the public have been effective. So we know that the number of deaths are much lower than were predicted at the beginning of the pandemic. And we know that the reason for that is the fact that people have complied with social distancing, that people have used appropriate PPE, that the NHS has treated people appropriately. And I think, at the beginning of the pandemic, there were mistakes made at a national level. But really, we know that the response, and once people complied with all of the measures, and once people got vaccinated, we saw the death rate significantly falling. So I think from our perspective, the important thing to stress is that vaccination really works. Vaccination prevents deaths, it prevents hospitalisation, and we'd encourage everyone to get vaccinated.
Keep on doing that one. That's my kind of train service announcement, isn't it? I've got Graham, and then I've got, I think, some councillors over there.
Thank you. Really excellent presentation, but I think I see this as a challenge, really. I think we've got a number of areas in our community where people have done much less well than others, and I don't think we understand it fully. So we can explain this away. We can say, well, it's because people have got more deprived backgrounds, they've got more illnesses, or have we got more care homes in those patches? But for example, if there's more care homes in some of those patches, who works into those care homes, and what impact did it have on their families, and did they spread it into their communities? And do the parallels that we see here actually, are they parallel to many other reasons why we have inequalities in Northumberland? And actually, is this a really good indicator of which communities we need to understand more? And it just dovetails really well with the whole population health way of looking at things and inequalities. And I think we should use this. If we went to some of the leaders in the communities where this has happened and said to them, here's some information for you, what do you think about it? Well, if I lived there, I would be appalled, and I would say, what are you doing? So I think it's our responsibility as a system to actually take this away and understand it better and do more with it. I don't think we can just be passengers and say, well, yeah, that's interesting, thank you. We can explain it because of the differences in the populations. Actually, it's now, so what now for me? And I think we can do something with this, but I think it fits with lots of other information that we also have.
Thank you for that, Graham. Did I see Glenn Sanderson?
Yeah, thank you very much. I think that's a really good response, actually, Graham, from what's been talked about, and I think it is something that the administration is taking seriously. And Wendy and I have had meetings with Phil and others, and we will do more on this. I think my main question was, where are we going to go with this report now? Because I think it's very important that we highlight the key messages in it, not least because about a year ago now, I'd become leader, and we had to make some really difficult decisions that were politically unpopular, like, for example, joining up with the LA7 to share resources and expertise. And then some parts of the county were very reluctant, very cynical about the need for social distancing, for the measures that we brought in. Indeed, I was lucky enough to receive many from one particular ward, really nasty emails about how ridiculous this all was and how stupid we were being. So in a way, I felt we were doing the right thing then, and I'm absolutely sure that we did the right thing, and I'm very grateful to all the health, and particularly Liz, who was a huge assistance to me then. So I would like us to be able to say this could have been a lot worse, and it is right that we did take the measures we did. So I would ask Phil, to see what we might be able to do with this, because it's very important. Thank you.
Thank you, Ben. Is there any other points or questions? I've got David there.
Thank you. So do I take it there will be a report on lessons learned and potential actions presented to this committee or elsewhere at some future date?
Well, I'd very much welcome it in the chair's position here. I'm looking at our experts here to see if that's something that would be possible, or is that something we can do and look at? Yes, excellent. Well, timing on that's an interesting one.
It might not be possible to answer this, but might there be some time scale to aim for?
Yeah, I'm looking now. I think that's possibly something to take outside this meeting and come back to on the best time. I suppose it depends on many things. If it was just, things would get worse than we perhaps anticipate, then I think you'd probably want me to deal with that rather than the report, wouldn't you? But yes. Yeah.
Chair, I think this could really work through our System Transformation Board, and I think it's so important that we need to have action ready for the new financial year.
Yeah, certainly agree.
Could I just add to that, please? I think if we could do a kind of, not the whole presentation, but some really important parts to go to all members, because I think it's very important that they understand this and actually buy into it.
I agree with that, and I was just going to ask if this document could be perhaps passed to members, because I found that very, very easy to interpretate and very easy to read what the messages was in that. So I think that would be useful to go to all members if that's possible. So I'm sure we can take that out this meeting. Any more points on that? Carl. Oh, sorry, Graham.
I think just to clarify then, I think what we've said is that we can take this forward to the System Transformation Board as a case for further work amongst the officers between our organisations. I also wonder where it fits with the JSNA and when that feeds into us, and that fits with what Siobhan has just said about having a plan for next year. So I think if we can take what we know from COVID and also what we know about the rest of the needs of the population, it starts to allow us to focus on what we should all be doing together, and that's that joint strategy around population health.
Yeah. Thank you, Graham. Right, on that, I'm going to pass to Phil Hunter, because I know Phil's got to get on, so I'll let you do your presentation.
Thank you, Chair. This is just a very brief update on communications and engagement activity in relation to COVID. As ever, there's been lots of activity in recent weeks, although this should be a familiar set of slides and messages for the board. And I should say thanks to Claire Malone and her team for the fantastic job that they have done and continue to do on all of this activity. I'm sure it's very much appreciated by the board. So in terms of what we are doing, well, we're continuing to amplify national and local COVID messages. This includes the latest updates, guidance and advice. It covers everything from I suppose the very simple, encouraging people to wash their hands regularly or stay at home if they're feeling unwell, to explaining the importance of being vaccinated when eligible and how to access those vaccination resources. And of course, we continue to share our latest COVID stats every day on our social media channels. We continue with our ongoing work, so supporting the outbreak prevention groups that Liz covered earlier on in her presentation, meeting regularly with partners in the local resilience forum, communications group, keeping our MPs and our elected members well briefed. I hope they would agree. Linking in with government communications, really important, and implementing and passing on the key messages that are coming out of national government on this. Supporting the recruitment and writing weekly updates for the community champions, and I'll come back to that later. And of course, working closely with neighbouring authorities on our regional Beat COVID North East communications activity. Again, I'll touch on that very quickly. Just in terms of the community champions, we now have over 50 champions that have signed up. Around 38 of them are actively sharing our messages, which is really positive, because it's always better to sort of communicate those messages through people who are embedded in communities up and down the county. But we still want to build on that, and I think we can do that. We are providing those community champions with the latest information, advice and guidance on COVID, and obviously they help us by sharing clear information within their communities to help all of our residents make informed choices to stay safe. We are currently mapping locations of our community champions, and we're also developing a further recruitment drive so we can get more of those champions on board. And we're also looking to develop links with businesses to get them involved too. One of the things we've done, there's now a WhatsApp group that we've established for the community champions, and that simply makes it easier for those champions to share information between family and friendship groups. And in the next few weeks, we will be encouraging some of our young leaders to develop opportunities for younger people to be involved in our work too. As you know, the next phase of our Beat COVID North East campaign is up and running now. I'm sure, or I hope, many of the board members will have heard the radio ad, which I think strikes the right note. It frames all of the ways that we can choose to be kind to each other to reduce the spread of COVID in the North East, and that's been badged as COVID Acts of Kindness. In addition to the radio coverage, there's now TV, press and cinema advertising, and they're all active now and will run throughout this month. Nominations have closed for the COVID Acts of Kindness Community Awards. And as I said at the last meeting, those awards will celebrate individuals across the region who have gone above and beyond to support others during the COVID pandemic, and the winners will be announced at the end of this month. And along with the advertising, you'll also see continued PR activity and case studies, just to remind residents that COVID is still a serious threat, as was underlined in earlier presentations, and that will focus on younger individuals to encourage vaccination uptake. So in terms of next steps, well, obviously we'll continue to amplify national and regional campaign messaging. We'll continue to support our community champions and drive up the recruitment of those community champions. I've mentioned the Beat COVID North East campaign, that's ongoing. We will continue to support the vaccination program, addressing hesitancy and adapting materials where needed. And we'll also see further behaviour insight work carried out across the region as part of that Beat COVID North East campaign activity, just to assess how effective that has been. So that's a very brief update, Chair. I'm happy to take any comments or questions.
Okay, I've got David.
Thank you. And thanks for the presentation and for the relentlessly positive approach you've taken over the last year and a half to, to communicate with the wider population, because it will have made a difference. But in terms of next steps, would it be worth adding to the list, as has been mentioned before, the 12 to 15-year-olds? Because although they're perhaps not hard to reach, because they're all in school, they are possibly hard to convince. So perhaps there should be efforts to redouble the communication with people of that age, to help them to make their minds up, to make a more positive decision about the benefits of having had the vaccine. Just a suggestion to add that to your next steps.
Yes,
Thank you.
Absolutely, fair point. And I know the team are working hard to relay all the messages and all the materials that we're getting from government on that. But you know, I'll certainly pick up that comment and ensure that we redouble our efforts on that.
Thank you. Just to add to that, people of that age group tend to look at different media to what they don't watch television in the same way we do. You know, on Snapchats and TikToks and all this kind of stuff. Yes, Claire.
It's just to pick up on that point that the NHS nationally have got quite a lot of resource specifically targeting young people using the different mediums that you've referred to there, Chair. So there's a huge amount of resource, and I know that Northumberland Council and all of the NHS bodies are trying to push it out as much as possible. But anything more we can do will only be of benefit.
Thank you. I've got one point. It's COVID isn't leading the news articles anymore, on the news stories anymore. So is this a new, we're probably going to have a new kind of stage in terms of reminding on this, because of it will start dropping off people's radars, I feel. And is that something that we've factored into? I'm sure it is, but
I think it's a very good point, Chair. I mean, obviously, we in communications, we can't make the news or lead that agenda. Sometimes we wish we could, but yeah, I think that is something that we can certainly factor into our future plans.
Any more points from anyone there? No. Okay. Well, thank you very much for all that. I know people have got good things to do today as well, so. A very sobering update as ever, and thank you everyone for your hard work on that. It's some very good reports to read in terms of their ease of reading, so I thank you very much for that. Thank you. Okay, I'm going to return to the agenda now and go to point 5 on the agenda, which is SEND Revisit May 2021, to inform members of the findings of the SEND Revisit from Ofsted and the CQC and the next steps to be taken. And looking who's leading on that one, who's going on? Rachel. Okay, thank you, Rachel. Over to you.
Thank you, no problem. Well, I'll just see if this works. Oh, I've pressed the wrong button. That's it, great. Thanks very much. So we were lucky enough to receive a call on the 5th of September. That was Northumberland CCG and the local authority received a call that we were going to be revisited to look at our SEND services, which are special educational needs and disabilities. And we were given 2 weeks to prepare, and then we had a HMI lead inspector and a CQC inspector came on the 19th and the 21st till the 21st of May. They focused on 3 areas of particular weakness that were flagged from the first inspection, which was around our joint commissioning, the quality of our educational healthcare planning, and academic outcomes for young people, as well as preparing for adulthood, were the sort of areas of focus. So we had to send a huge amount of written evidence on the progress that we had made. They spoke to the colleagues at NHS England and Department of Education who had been monitoring our progress, and they met a number of frontline practitioners, senior leaders from across education, health and care services. They also met the Parent and Carer Forum and talked to them, and then they audited a collection of care plans, educational healthcare plans, and they also spoke to parents. The inspection was very, very positive, and they highlighted a number of key strengths. One was around our collegiate approach to the delivery of SEND developments. They liked the revised and revitalised strategy for children and young people. They noted an improvement in the quality of our plans. They were very impressed by our strong waiting times, which is quite very short waiting times compared to nationally for children accessing mental health services. Our good understanding and the importance of early identification and the work that we had done around that, and the graduated response across the SENCOs in education and the consistency of that across all the schools. They were impressed with the strong parent carer forum, how they managed to provide really good challenge into our SEND partnership, and the improving picture within the academic outcomes across the school for SEND learners. So the outcome was really positive, and we were able to demonstrate sufficient progress against those 3 areas that they were particularly interested in looking at. And so this is really good news for us in Northumberland now. So the formal support we were getting from the Department of Education and NHS England has now stopped. And, you know, they actually noted the significant improvement and used this great word, you know, seismic change in leadership and culture in Northumberland since it was last inspected in October 2018, which was really positive. We did need things are always set into the judgment was set into some context of that there is always still more to do. There was, especially around the preparing children for adulthood and in our supporting inclusive education were the sort of areas that we still absolutely need to improve on. But I think they also valued our great honesty in understanding ourselves and where we were, and that we had good plans in place to improve those. So the next steps really were then to deliver on the strategy, and our 4 key areas of that strategy is to continue to work together around obviously good communication strategy, increasing the understanding by working with children who've got lived experience and their families, delivering the right support at the right time, how we join up our services, particularly across health and social care. So supporting children with sensory processing difficulties is one of our key areas, and further improving the identification of learners, particularly with ASD, and particular focus on girls. Inclusive education is the next strategic priority, so workforce development from school settings and practitioners across health and social care, getting them to work more closely together, improved leadership and delivery for support to SEND learners in our mainstream schools. And then finally, as I've mentioned, the preparation for adulthood, so looking at careers offers overseen by our preparation for adulthood lead, and increasing a range of post-16 options. And obviously there's work ongoing in all of those areas, and that's the end of my update. Thank you.
Thank you very much for that positive report. Has anyone got any questions or points? Yes.
Thank you, Chair. I was part of this, and it was a really fabulous experience of system working. So well done to everyone involved. In terms of next steps and actions, I think we're at a really pivotal time in terms of more opportunities around joint commissioning for children's services, and also children being intrinsic and parents in the design of those services. So getting into co-design and co-production, and not just professionals telling people what is needed. So I think it's a really exciting time ahead, and there's no way we're sitting on our laurels despite the amazing outcome from CQC in Ofsted.
Thank you. Glenn Sanderson.
Thank you. I just simply want to say thank you to all our officers and all those that helped get this improvement made. It's a very significant bit of improvement and progress. So all I can say on behalf of the elected members is thank you very much.
Thank you. Yes, David?
I think just echo that it must be unusual, if not unique, for an organisation like Ofsted to use the word seismic. You know, that's a big word. So just echo what people have said. You know, there must have been a huge amount of work behind the scenes to achieve this improvement, and delighted that has been said that the momentum will be maintained, which is equally critical. So, you know, that's a huge achievement. So, you know, so well done.
Absolutely, echo all of that. Any more points or questions? I think we can close that item then. Thank you very much for that, and thanks for everyone's comments. Okay, so the next item on the agenda, which is to do with physical education, physical activity, if I remember, and that's Northumberland Physical Activity Strategy. Lee Sprudd. Thank you.
Thanks, Chair. Just checking everyone can hear me. So I'm Lee Sprudd. I'm the Strategic Director for RISE North East, which is the active partnership for Northumberland and Tyne and Wear. And just to put that into context, the main purpose of our organisation, which is primarily funded by Sport England, is to tackle inactivity and obviously the complex issues associated with that. So when I last sat before this board in May 2019, the world was obviously at different places we've outlined. I sought approval from members to develop a county physical activity strategy, one that used a systemed leadership approach to tackle inactivity. So I'm here today to provide you with an update of what's happened since. So we were delighted to launch a strategy in January 2020, following extensive consultation with stakeholders, many of which were from the VCSE community. A link to the online platform, where this strategy lives, is located within the report. And members will note that this is actually designed to tackle the wider health and well-being issues associated with rising inactivity levels, which have now been exacerbated by COVID. Before I touch upon briefly what the progress we've made to date has been, I just thought it was important for members to just to provide some context on the impact of COVID. I've shared some presentations. I'm not going to go through them today. Hopefully they kind of make sense, but it's just to paint a picture of kind of, and this is intelligence from Sport England, by the way. So this is just to paint a picture of kind of what the impact of the pandemic has been. So nationally, the impact of the pandemic has had unprecedented impact on everybody's ability to take part in sport, physical activity. It's disproportionately impacted on several groups, including those from lower socioeconomic groups, obviously those living in the most deprived areas, those with a disability or a long-term health condition, or living with comorbidities, and those from our ethnically diverse communities. What this means for Northumberland statistically, which is a concern, is we have a statistical increase in the adult activity levels, which have risen from 20.9% to 28.6%, and that's between November 2018-19 and November 2019-20. Obviously, we're awaiting the latest results next month. Obviously, that's a very deep concern, and just to make everybody aware what we mean by the measurement in activities, adults over the age of 16 not doing 30 minutes of any type of exercise over the week. So this can constitute just simple walking in terms of getting your heart rate pumping more than it usually would do. 38.4% of those are actually living in our most deprived areas in Northumberland. So obviously that's it is of great concern. And 45.9% of adults with disabilities or long-term health conditions are inactive. We are above the national averages across all of these measures, which is obviously concerning. For children and young people, there has been a statistical decrease in the number of children who are less active. We know from Sport England's research that 46.6% of children and young people between the ages of 5 to 16 failing to meet the Chief Medical Officer's guidance of being active for 60 minutes per day, which is obviously what they need to be doing across Northumberland. And this actually worryingly rises to in excess of 60% in our most deprived areas. In summary, the impact of the pandemic has created significant challenges linked to the already complexity associated with physical inactivity. This is now exacerbating the wider issues, which you will all be aware of in this board, which this strategy is designed to support. And this includes mental health issues, rise in obesity levels, loneliness and isolation, and rise in unemployment, to name a few. So I'll come on to the good news. Thanks to the dedication and hard work from partners and stakeholders across Northumberland, and I'll emphasise this is a truly multi-agency approach to tackling inactivity. It doesn't belong to any one organisation. This is a first for the country as well, and it's recognised by national partners, including Sport England, as a best practice example. So we are on track to deliver the shared outcomes, which is in the Appendix 3, which is the kind of logic model which was used to capture the short, medium and long-term outcomes for this strategy, which is designed to support the joint health and wellbeing strategy in Northumberland. So I won't go through all the highlights, but as I've said, there's lots of work going on at the moment. This is around, the framework is all designed around developing inactive enablers. So this is the system change stuff that needs to happen. I've heard a few times in today's kind of meeting the word hard to reach groups. And one of my colleagues in Sport England actually got reprimanded for using that term whilst he was actually consulting with a local community down in Birmingham, because he was addressing an ethnically diverse community, and they basically just turned around and said, we're not hard to reach, you're just not reaching us. And I think that was a very good use of the phrase, and I think actually it made lots of people in Sport England and colleagues of ours kind of sit up and think, actually, this is around system change, this is around coordinating, collaborating efforts to pool resources to really reach out to those most vulnerable people within our communities. We also are looking to develop an active society, so this is working with the communities, and this is around developing kind of active environments. So we are looking, well, we're not looking, the principles of active design around creating well-designed places and spaces to encourage people to be more active are now going to be embedded within the new Northumberland local plan, which hopefully will be adopted later this year. There's some fantastic work going on as well. You know, I won't go through all the examples, but they're highlighted in there. I think the Northumberland Communities Together work through the County Council and partners has been fantastic, especially linked to the summer holiday activities and food programme. Again, targeting lots of our most vulnerable children and young people, and providing them with multi-sport opportunities. Again, emphasising the importance of keeping active. So we are not, so just to emphasise, I'm not talking about putting people into structured, organised sports. This is purely getting people moving, getting people active. This is from a cradle to grave approach. And obviously, you know, they working with older people, for example, the deconditioning of those because of the pandemic, and as we go through the recovery, it's even more important that we obviously recognise their needs and design interventions which actually meet those needs. So if they, you know, whatever sort of long-term health conditions they are suffering with, and I say we, it is a collective we need to work together to actually understand those and make sure that we design those activities which meet their needs. Just one of the key elements I'd like to kind of just flag is we are, through the strategy development and design of this, we were focused on developing place-based approaches. So we've there is one developed now in Berwick, working with the Police and Crime Commissioning team, the council, NHS Trust, and other partners. And this is to address the serious concerns around the young male suicide rates. So this is again placing physical activity at the heart of interventions, but it's not the only thing that's obviously going to help them. There is a link worker embedded now within the Berwick Community Trust, who's actually now acting as a referral conduit for young men living in the Berwick area. So again, the learning from that type of pilot will be fed back into the kind of decision-making processes, which is at the moment, in terms of the governance, we still have a physical activity steering group, which Liz Morgan chairs for us. And again, that is a multi-agency group which kind of looks at all of this. And I think it was, like I said, there are key things in here. I mean, actually, the final one I'll kind of draw upon because I think it's been it's a key piece of work which is going on, and we're expecting further investment into this. Is the opening school facilities funding from Sport England. So this is focusing on those schools with the most economically disadvantaged students. So students with the free school meals and the pupil premium kind of figures are obviously providing us the insight on who to target and who to work with. Again, most of you will be aware, you know, we have some fantastic assets within our school-based sites that are not being used. This is obviously the same across the country. You know, school sites being closed on weekends, after school, which, you know, is criminal in some respects, but it's actually working with the schools and obviously partners to actually understand why they're not opening to community access, because actually, like I said, there's some, especially in more of our rural isolated areas in Northumberland, this should be a valuable asset in terms of a community-based intervention. So, in terms of the recommendations, I kind of just want members on the board here to kind of understand and acknowledge the importance of physical activity, this strategy, in terms of tackling the wider health inequalities that we know exist, recognise the complexities associated with tackling inactivity, note the immediate impact of obviously targeting vulnerable communities and people hit hardest by COVID-19. Note the significant benefits of obviously adopting a place-based approach to really understanding and meeting the needs of those people in those communities. And that's it, Chair. I'll stop there and I'll invite any questions if anyone's got any.
Okay, has anyone got any questions? I'll go to Jeff, and obviously it's linked to your portfolio.
Yeah, thank you. Thank you, Chair. As most people probably know, I'm involved with Active Northumberland. Just to say that this report kind of reflects our attitude. This council takes healthy lives of our residents very, very seriously indeed, and we're doing enormous things to try and help improve those lives. And I think we can justify that by saying, if you are aware of what we're doing. If you're not, I'm going to remind you. We've just opened, for example, Ponteland Leisure Centre. We're in the process of just about opening the Berwick Leisure Centre. We're rebuilding the Morpeth Leisure Centre. We've just reopened £5 million improvements to the Blythe Sports Centre. We've closed Newbiggin Sports Centre because we're improving that. We've got good facilities at Hexham and Alnwick. Ashington is first class. Cramlington and Prudhoe will probably be on the list for some more improvements in a few years. But we are taking this really, really seriously, and we think that this report is good, and it reflects our attitude to what we are trying to do as well. We are wanting to make healthy lives of children, particularly across the whole community, not just the better off children, but disadvantaged children as well. But we want to treat them all the same, because we want them all to have healthy lives. And that's what we're trying to do. And I think the council are doing a really good job. And if you look across the nation as a whole and see what's happening elsewhere and comparing it to what we are doing, for example, there's 140 swimming pools being closed nationally at the ceasing of the COVID pandemic. And what are we doing? We're actually opening some. So I think we've got the message, and we continue to work to do the best we can for our residents and our children. Thank you, Chair.
Thank you for that, Jeff. Well said. Yes, Lee?
Sorry, can I just to echo Jeff's point there, I think our active rates, so those are the people who are hitting the 150 minutes per week, are way above the national averages, and I think that is a testament to the work the County Council, Active Northumberland and other partners have been doing. And obviously I would encourage that to continue because these active residents can easily slip into, I guess, being non-active due to life circumstances. And they're the sort of things that we just need to continually keep on the radar. But yeah, actually really echo your point here, Jeff.
David.
Thank you. Thanks for the report and the work which is going on across the board and in an integrated way. But I sense from the report and from what you have said that there may be a reluctance within some school establishments to open up their facilities, for the wider community. If that is correct, what would you suggest could be done to try to improve that so more facilities are available, particularly in the rural areas? Thank you.
Thanks, that's a good question. There is a lot of work in terms of the evaluation going on at the moment because we were involved in the initial pilot as well 2 years ago. So we are looking at those schools who are opening up their facilities and actually evaluating the success of those. And I think it's easier then to go to schools who are reluctant. A lot of it is down to kind of the economic situation, paying for caretakers, for example, to open up facilities or having capacity to basically be able to do that. And I think actually showcasing the benefits of opening up these facilities on a wider, in terms of a wider outcome basis, we just need to build the evidence really and showcase business managers, head teachers, principals, governors, and actually showcase the importance of their facilities, they are to their local communities. And I think a lot of the research we're actually unfolding already at the moment is showing that especially young people who are not active, going back to their school environments which they're comfortable with is actually encouraging them more and more to do so. So yes, it's just continually to build that intelligence and insight, really.
Thank you. Graham?
Thanks, Lee. Really good report, but the complexity of it all and the size of this, I mean, you've listed 8 enablers, which for me feels like too many to all work with. Do you see what I mean? And you've mentioned system a number of times in all of this. And I worry that perhaps you work in a way in isolation at multiple people at the system. I remember your launch event, and obviously the pandemic's got in its way, but coming to health and well-being and letting us know via this route to Northumberland is one way of doing it, but I would be interested to know how we can help you kind of embed some of this into everybody's business, so that we can kind of work it through, because exercise is one of the most important things that anybody can do, and for many cases it's free if you just make it a habit, and I don't think we necessarily have got that messaging entirely. I like the point about place-oriented stuff and and targeting and getting in amongst, so that example of Berwick is excellent, and I just wonder how we can do more of that type of thing, but so that we all know where these places are. You've got data. I'm not sure if what you know from Sport England feeds into our health improvement group. That's an unknown for me, so I'll have to go back and ask. But it is about joining you up better, I think.
Yeah, and I completely accept that point. I think just to kind of highlight most of the examples given, it's not led or some of them are not led by me or my team. I think it is, in terms of the system change stuff, it is actually working with strategic partners and actually understanding what their challenges are, what their, how, talking to them in terms of what they think system change could look like and how physical activity can be kind of embedded into that. I think, as an example I kind of gave, I think the local plan in terms of the planning and infrastructure is really important. I think, having kind of wider health impact assessments attached to a local plan. So our planners and kind of transport leads, for example, have kind of physical activity at the heart of some of their decision making. I think the climate change agenda at the moment is huge. Obviously, I think that obviously it's going to keep growing. I think the kind of links to the active travel, agenda is going to be key to this. But again, you're right. No, we can't do this in isolation. We do need to kind of work together. I mean, I have put in examples like the active hospitals pilot because I think that's an excellent piece of work. And it's one of 3, I think, in the country. And I think that's, again, we're not leading this. This is other capacity within the kind of system. But obviously, I would expect the Northumbria Healthcare Trust, because I know we're part of the kind of steering group, if you like, but actually that learning will be fed into the system, up here, because we would like to influence, obviously, other secondary and acute care settings. So I think, yes, there is lots of work going on. You're right, it does need to be more joined up. I think that is the challenge. But I do think, I do take your point. Try not to bite off too much.
Can I just come back? So commercial sector doesn't get a mention in here, and I wondered if there was something there, maybe not to answer that now, and then clarifying exactly. So you mentioned a coordinating group or a strategic group about activity in Northumberland. So how often does that meet? How does it feed into our other system partners? And maybe that's a conversation for outside if you wish, but I just think knowing that would be helpful.
No, and I think actually, if we're true to ourselves in terms of developing a whole system approach, you're right. The private sector absolutely have a foot in the door with this. We are talking to some private sector providers, including kind of transport leads, Nexus and Arriva and organisations like that, for example. But again, members on the group, need to come up with with their ideas in terms of where they see the kind of the key stakeholders that need to be part of some of the decision making moving forward. So yes, we are constantly reviewing the membership of the group on an annual basis. It meets quarterly, by the way.
Okay, thank you.
Well, I've got Jeff, then I've got Claire. So I'll bring Jeff in.
Thanks for letting me come back, Chair. Just one thing, Lee, that I think I've come across before is a hindrance to us, is that if some of the local groups want to do activities on school grounds, they have to pay the caretaker's fee, basically, which in many cases is quite a lot of money to a voluntary club. If that's something we can ever get a grip on and do something about, I think it would help. I mean, I've got several cases of running clubs and things who simply want to use a track, but they've got to get a caretaker to open up and close up, and it is really a problem. So if I can just point that out to you, Lee, for future work, perhaps.
I think I'd be happy to take, obviously, any individual support requests, obviously, outside of the meeting. But you're absolutely right. I think we do need to think about sustainable solutions. We don't, this isn't about 3 or 4 year kind of funding cycles where clubs have applied for grants, and once the grant runs out, the activity stops. Really, we need to upskill and empower our local communities to kind of, so it isn't just the caretaker, it is other people within those communities who've got the interest, who we can upskill to kind of deliver the activities which they want. So we're not imposing anything onto those communities, which I'm being honest now, I think in the past, powers that be have probably done that too often, and these things just, it was a good thing while it lasted, but once the money runs out, it stops. We can't afford to do that. We need like I said, more sustainable activities to be designed.
Just a few points to pick up. I think from a wider system point of view, I just wonder whether or not we need to consider how it fits into the wider debate with regards to the System Transformation Board again, just to make sure we've got that visibility as part of the broader plan. I think from a school's point of view, you make a really good point on the schools, but we know that there are, I think, head teachers boards. There is an education board, that's our committee for the council, and I just wonder whether or not we need to open the debate with them through those forums. And also just more widely is, you can have the best facilities in the world, but you need to really encourage people and look at behavioural change projects behind that to you can take a horse to water and you can't make a drink scenario. So we really need to make sure we use every touch point available to us to influence behaviour, and it's back to that cradle to grave point.
Yep. Don't disagree with that. Anything to add, Lee? No. Okay. Well, I've just got one point, and it's to do with how our lives change after COVID. And we've got far more people working from home. If you work from home, you walk downstairs to the kitchen or whatever, and that's all we do all day. You know, when you come into office, you know, you've usually got sort of like social groups of aerobics and walking groups and things like that. How are we going to adapt? You know, and you go and buy your sandwich, you go and walk to the bus stop, whatever. How are we going to adapt to changing habits with that? Because I'm noticing people are less mobile than they were. Is that something that we're considering? Is that something that's part of thinking at the moment?
Absolutely. I think the whole kind of workplace health agenda is huge at the moment, and obviously people's working patterns have obviously changed, and they'll probably change forever as a result of this. So workplace health, and you're right, it is, again, it's not just about putting on activities during the lunch hour or, you know, after work where you just hope people are going to come. This is actually working with people, working with obviously the multitude of lifestyle things everyone faces. It's kind of, and then you know, it is simply co-designing, and actually, because what works in one employer won't necessarily work with another employer. And I think, you know, even with an organisation the size of the council, for example, you know, one department is going to be completely different from another department. So we do need to be more proactive. I think we do, again, it's building our insight and intelligence, but it is using things like the Better Health at Work Awards scheme, and it is using the learning from those, and obviously making sure that actually those type of award schemes, which are fantastic, are actually recognised and they're truly culturally embedded within teams, and it's not just the people who enjoy sport or physical activity getting involved in activities. You know, we need to design things which, you know, you're absolutely right, it is a behavioural change framework we need, but when I say that, that doesn't happen overnight, and, you know, because the whole strategy talks about changing behaviours. You know, we've pretty much designed activity out of our lives for the last sort of 70, 80 years. You know, when you think about everything we do, we are up against it, shall we say? But we can only work with people, you know, and actually try and come up with some answers. I haven't got the answers, unfortunately, Chair, but it is probably the key question, that behavioural change.
I mean, I totally agree with it. Graham made important points about the private sector in terms of, I know I'm thinking of gyms here. A lot of people would let their gym memberships lapse and perhaps haven't gone back, perhaps read those editorials which said, oh, you should give up the gym now and just work out from home, which might be okay for a while, but then you get fed up with it, and then your weights get in the way, so they get packed away or whatever. So there's lots of challenges. It just concerns me how rapidly things have changed and what we might lose through that. It does concern me.
I think just on that, I think the natural assets Northumberland has, I think lends itself amazingly to developing these kind of opportunities, which, you know, are cost effective, in a lot of instances free. And I think one thing the pandemic did do is completely raise the profile of physical activity. You know, Professor Chris Whitty obviously talking about the importance of keeping active, but seeing families actually going out for walks and using our natural kind of assets and actually riding bikes. I know there's a cost to riding bikes, but actually last year we had a lot of investment where we were asked to support the most vulnerable people. We couldn't buy any bikes or purchase any bikes anywhere, and this was a national problem because people were just suddenly getting on their bikes and actually purchasing the bikes. So I think there are massive opportunities linked to the COVID, which I think we just need to seize on and actually don't lose any of the momentum, because I think, you know, that family engagement was you know, one of the positives, not many positives from the COVID, but actually that you know, getting out and just being active is what we want to see.
Okay, thank you for that. Wendy, yes.
Could I just finish off that with just, I think the two things we need to be more concerned about since COVID is obesity and mental health. I think we need to focus on those two things more than anything else, in my opinion.
Totally agree.
Yeah.
Okay, any more points? Have I done that? Great. Thank you very much for that. Very interesting. Thank you very much. I'll go on to the next point, is the Health and Wellbeing Forward Plan, page 45 to 50. Just to note what is on that. You can see what's coming up on the next meeting there. David, did you have something to say there? I thought you might. Sorry.
Can I just say something on that point? So on the next plan, we've got an ICS and STB update, and I think it's becoming increasingly apparent that the Health and Wellbeing Board is going to have to dovetail very well with our place-based system working in the new world of having this thing called an ICS. And the ICS is currently in formation, and we'll probably get more guidance about what our ICS thinks our place should look like from an organisation point of view. I'm fully aware that some of our local authority members are involved in design sessions at the minute for our ICS, so we're waiting for the feedback from them. But I do think, as a Health and Wellbeing Board, in the next couple of months, we need to be just thinking a bit more about how we ensure what we perceive are the needs of the population and the people, and how that's working, feed into the wider partners. And I think the physical activity thing has highlighted that as well today, and what we've seen from Liz. So we will need to focus on that a little bit more in the coming meetings. Thanks, Barry.
Okay, yeah, Wendy.
Just actually echoing what Graham says, I think integrated care systems is something we really have to focus on. We know that CCG are going to be absorbed into that, and I would like to know where the Health and Wellbeing Board is going to fit in. And that's really important, because I don't think at the moment we're doing enough to bring this forward. So I would really like possibly a full discussion, the whole meeting, about where we go once we get a bit more information. I think it's very important.
Thank you for that, Wendy. Urgent business. I have no urgent business. And the date of the next meeting is Thursday, the 11th of November at 10 o'clock. God willing, I'll be on an aeroplane at that time, so I have to put my apologies in for that. But I've got a safe pair of hands in Graham to chair the meeting. So thank you very much, everyone, for coming, and I shall see you in December if I don't see you before. Thank you.